maybe I'll just get started. Hello, everyone. Welcome to our late spring edition of NU-HTA's User Spotlight series. So for those of you who don't know me, I'm Sarah Dunn. I'm the manager of Northwestern's high-throughput analysis core. So if you're not familiar with the core, we provide the instruments and the expertise needed to do high-throughput biological screening. And we'll train people for walk-up use of the instruments, or we can design and perform experiments for screening projects for anyone that needs, a more service-oriented approach. So I've been organizing these user spotlights, both to give our users the opportunity to, showcase their incredible work, and also as a way to introduce the core to more researchers at Northwestern. So today I'm excited to introduce Malorie Blancard. She's a Postdoctoral Fellow in Paul Burridge's lab. She's going to tell you about the work she's doing with the iPSC models of sudden cardiac death. So Malorie is an expert user in one of the instruments in the core. I'll let her tell you more about it. And so she and I first started working together when we were getting trained on that instrument. And honestly, she's been a great resource to me in developing the service. Malorie, take it away.
Well, thank you everyone for coming. So as Sarah said, I'm going to give a talk about my project, which is about modeling sudden cardiac death using an iPS model. So first, I wanted to give an introduction about the electrical activity, since we're not all working on heart disease. So the electrical activity of the heart is automatically generated in the sinus node, and then it will travel through the walls of the right atrium to the atrioventricular node. And then the conduction system will enter in the ventricles. And at that moment, the electrical activity will slow down. And then you can see that the conduction system will be divided in the right and the left button branches. And then, oh, where is my pointer? Here. And then the electrical activity will spread through the ventricles using the Purkinje fibers. So what is the electrical activity? It's made of action potential. And I wanted to show you that depending on where you are at on the connections in the connection system, the shape of the action potential is different. So for example, if you take the atrial muscle action potential, it's shorter than the ventricle one. And that's the one I'm more interested in this talk. And the sum of all this action potential, you can see them on the electrocardiogram. So I want to make sure everyone understand that part, because I'm going to use it later to talk about the system that is available on the core. So you have here the P wave that corresponds to the atrial depolarization. So if you look at the action potential here, it definitely matches. So it's when the two atria will contract. Then you have the QRS complex, which match this moment with the ventricular muscle. So it's going to contract, the ventricle are going to contract. And then the T wave is the relaxation. So it's the repolarization of the ventricles. So the ventricle are going to relax. And maybe some of you can ask me why we don't see the relaxation of the atria. It's because it happens exactly during the QRS. So when the ventricle are contracting, the atrium, the two atria are relaxing. So that's why you can't see that wave. And so I also wanted to go a little bit deeper in the action potential and how it works. So you have the first phase here in green, that is of sodium through the cardiac sodium channel. Then you start the repolarization with an efflux of potassium. And then you have the plateau phase. We call it the plateau phase because you have at the same time an entrance, you have the calcium that is entering the cell and the potassium leaving, so you have this plateau. And then you go back to complete repolarization with a really big quantity of potassium leaving the cell. So I just explain what is like the normal function of the heart and how the action potential. So then I want to switch more about like arrhythmia. So of course there are heart rhythm abnormalities, and they can be due to, so all the action potential is the formation of it, like there is a problem, or the action potential is like creating fine in the sinus node, but the conduction in the connection system that I described, the problem will happen. So here I just wanted to describe like mechanism that then that you can definitely be able to observe on the machine in the course. So I just wanted to show you. So you have the depolarization, repolarization, classic action potential, and then sometimes due to mutation in an ion channel or other reasons, instead of like going back to baseline and have the repolarization, you can have some depolarization. And if it's big enough, it will create a new action potential, which is really bad, because if you have a new action potential, you can it can trigger like the contraction of the ventricle where the heart is supposed to relax. So that's when an arrhythmia can happen, when the heart is supposed to be relaxing and you have another contraction coming. It can just make it complicated. And then another type, which is delayed after depolarization. So the difference is just you had the time to go back to baseline, and then you had those small depolarization, and it's the same. Sometimes it's big enough to trigger an action potential. So those mechanisms, they will trigger arrhythmia, and you have like two main arrhythmias. So the atrial, the one impacting the atrial, the two atria, so the atrial fibrillation is the most frequent one, and a lot of people, I mean, clinician can correct me, but most of us, we're going to have it when we age, or like a lot of people have it around like 8 years old. And then you have the ventricular fibrillation, which is the more serious one, and it's the one we're going to focus in this talk. So here you can see a normal sinus rhythm on the EKG. You've seen like all the waves I've described. Then it can turn to ventricular fibrillation. So you can see it's like a complete disorganized rhythm. And at that moment, the patient like probably will have a syncope. And then sometimes it resolves by itself, and sometimes it doesn't. And then it can degenerate in asystole, so like no signal. And this is when the patient will have a cardiac arrest. And so sudden death, and I'm going to talk about that. So the definition of the sudden cardiac death and SCE, it's the unexpected cardiac arrest in less than an hour from the onset of symptoms. So that's how it's defined. And it's interesting to see that the etiology of it depends on the age of the patient. In older population, SCD is mainly due to coronary artery disease. You can see it's like 70%. But when you switch to like people are like younger than 35 or 40 years old, it's only like coronary artery disease are like 24%. So SCD is mainly attributed to a genetic cause, but not to coronary artery disease. So since I was talking about genetics, just to explain a little bit, and it's going to help you understand that the end of the talk, I made here in this diagram like 4 syndrome that are like due to mutation in ion channels. And the first one I just wanted to spend a bit more time on it is the long QT syndrome. So as you can see, it's pretty easy to understand. It's the name of the syndrome as in the name. So you have the QT interval that you can measure on any EKG that is usually like corrected by the beat rate. And then the patient, they will have a longer QT interval. So that's pretty easy to see. And that would trigger arrhythmia and sudden death. And another one, the Brugada syndrome, that is mainly due to mutation in the cardiac sodium channel. So the same, you have like the normal EKG, and here you have a specific abnormality that you can see on the EKG. So all this syndrome, you do an EKG on the patient and you can diagnose them. So why this is important? It's because we want, like as a clinician, I guess what you really want to do is be able to, if you have a patient coming that already had a cardiac arrest, you want to be able to tell that person if that person is at risk to have another one. So do you have to put more drugs or no? And also when you have, for example, a patient that has a mutation and you have a sibling or parent that had that mutation, you want to be able to tell that person, like, yes, you're carrying the mutation and you are exposed and you're going to be at risk for cardiac arrest, or no, maybe just by taking drugs, you're going to be okay. This is really difficult. So right now, for the current prediction, what the physicians are using, so of course, the clinical evaluation. So what I showed you before, like on the EKG, they will look for like abnormalities. They are also doing commercial genetic testing. All the genes I've shown you just before, they will look for a mutation. And then they will decide what's the best treatment. So usually they would give antiarrhythmics drugs, sometimes beta blockers. And it's also another option they have, and it's really important for my project. The physician can place an ICD, which is an implantable cardioverter defibrillator. And so the problem of that right now is that we still, like a lot of patients, they received an ICD because we thought they were at risk, but like 10 years later, follow up 10 years, the defibrillator like never delivered any shock. So the patient kind of didn't need, I guess, the ICD, but was exposed to all the risk of ICD, which is infection, the pain of inappropriate shocks. You have a lot of things. And on the other side, you have, we have still like a lot of case of SCD happening. So we need to find a more sensitive way to avoid unnecessary ICD therapy, and at the same time to better identify who is at risk. So I am lucky to work on this great project called the Northwestern Sudden Death Collaboration that has been divided into two projects. The first one is the creation of an algorithm called the arrest score that is going to be based on genomic data to predict the risk. And this is, I'm not responsible of that part of the project. I'm responsible for the product number 2, which is modeling the risk using a cellular model. So how can we improve the SCD risk, and how with the project 2 we want to do it? So what we aim to do, if we want to do, is collect blood from a patient or relative. Then I would, or someone else would, generate IPS. Then we would do the phenotyping of the cardiomyocyte. And then if we see that the cardiomyocyte, they fit in the low risk category, then we would be able to tell the patient, you don't need an ICD. And on the other side, if the cardiomyocyte, they are matching like the high risk feature, then the physician would know, like, okay, this patient need an ICD. So to do that, we have created like 6 different categories. So I'm going to explain a little bit. Category 1, 2, and 3 are low risk. 4, 5, and 6, high risk. Category 1, it's easy, it's control. Category 2 to 6 is all patients that have arrhythmia or syndromes that I've described before. The difference between category 2 and the category 3 is that the category 3, the patient, they received an ICD, and that's what we call primary prevention. It's because the patient received an ICD and had never had a cardiac arrest. So it was the physician that, because maybe the patient had a mutation or had syncope or other reasons, will decide to put an ICD. So for that reason, you're on the low risk side of this graph. And then when you switch to the high risk, category 4, it's patient that received an ICD secondary prevention, meaning they had the ICD after having a cardiac arrest. And the difference between category 4 and 5 is that when you do the follow-up of the patient's category 4, the ICD never delivered any shocks. Whereas in category 5, the ICD delivered at least one appropriate shock. So it can be one shock, but we have a patient, for example, that got 19. So it's just at least one. And then category 6, unfortunately, is like patient that died. And so, of course, from them, I was not able to get any blood. So the recruitment, the aim first was to recruit like 60 patients, so 12 in each categories. So the recruitment is done. We've been able to recruit 91 patients among the 5 categories. And so in blue, I just represented all the cell line that I've already reprogrammed. So I've reprogrammed so far 43 iPS line from blood. And since instead of first comparing category 1 to 2, 1 to 3, we have decided to first compare category 1 to category 5, since they are the extreme categories. So what's exactly my pipeline? First step, as I said, it's iPS reprogramming. Then I did the differentiation into cardiomyocyte. Third step, sorry, at day 16, in order to make my life easier and also to reduce the batch-to-batch viability, I was cryopreserving the cells at day 16. And then when I had enough cardiomyocytes from category 1 and category 5, then I was planning my experiment and then thawing my cells, leaving them 14 days in maturation media. And at day 30, I would do the phenotyping. So you've seen like there are a lot of lines. So we need high throughput system. So those three, the one that I'm using during my project. The first one, the Flexcyte, is the one that Sarah was talking about, and I'm going to spend more time on it because it's available in the core. Then I also do calcium imaging to see the calcium transient of the cardiomyocytes. And then the last one is the automatic patch clamp, so the synchro patch, where we can measure like sodium, calcium, potassium, and also action potential, which is pretty cool. And so at the beginning of my postdoc, when I was getting the blood and reprogramming the cells, at the same time, I needed to optimize all those systems. So forgot to also say that the cells will also be like exposed to drugs to see if the exposition to drug we would see a difference. It would trigger arrhythmia, and that would be the only way to see a difference between category 1 and category 5. And so what I wanted to say is that I've used positive control cells to optimize this 3 system. At the same time, I was reprogramming my patient, the cells. So for you to understand what I'm going to show you after, I wanted to explain my positive control cells. So they are calmodulinopathy lines. It means patients that have a heterozygous mutation in one of the 3 calmodulin gene. And so the syndrome is called calmodulinopathy. So I put this diagram is the same you saw before, and it's because here are the 3 genes. So that was just a little reminder. It's a really severe disease because 68% will experience a cardiac arrest before the age of 5 years old. So it's really hard. There are 2 main clinical phenotypes. The first one, LQT syndrome, that I already explained. And to give you an idea, the normal QT corrected to the bit rate, so the QTC, is 470 for all of us controls. And for the calmodulinopathy patient, the QTC is around 600, which is really, really extreme. And then the other phenotype is catecholaminergic polymorphic ventricular tachycardia. I'm not going to talk about it a lot, but it's specific type of arrhythmia that is triggered by stress. So people like biking, swimming, or they have acute emotion, and then they would die from that. They would have a cardiac arrest and die. So regarding the cellular phenotypes, what was I expecting? We expect to see a prolonged repolarization, which is what you see on the EKG. And so that's mainly what I'm going to show you after that I've been able to reproduce on the machine. There is something else that we can see is a decreased calcium channel dependent inactivation, but it's using another machine that is not in the course. I'm not going to detail that. So as I said, first thing I'm going to do is talk to you about the Flexcyte, which is available in the core. So what is it? You can do some monolayer experiments, cells on 2D culture. You can measure impedance, which is kind of the contractility of the cells, and also the extracellular field potential. So it's a 96 format. And so this is a slide that I got from Nanion, where the machine is from. So to just explain a bit, so you have a control environment. So the cells are like 37. You have the CO2 at 5. You can you have the CO2, and you also have like a humidity. So it's really like an incubator. So you can leave your cells for like 48 hours if you want. There is absolutely no problem. You have the option to do optical or electrical stimulation. That's something I've used. I will show you later on. There is also like a liquid handling system if you want to use it. And I guess here was to tell you that you can, at the same time, on the same cells, you can record the impedance signal and the EFP. So it's a really cool machine. So the impedance, what it is. So this is what you expect to see. So you can follow the contraction of the cardiomyocytes. So you can, all the parameters you can measure are like amplitude, the beat interval, which will give you the beat rate. You can also measure the pulse width, which is really interesting for me because I expect this part is supposed to reflect the relaxation of the cardiomyocytes. So that's where I would expect my disease line to be different. You also have the rise time and the fall time. You also have like upstroke velocity and downstroke velocity. And another parameter that is really cool for us, that is the beat rate regularity. It ranges from 0 to 1. 1 would mean like a perfect regular rhythm. So it's actual like screenshot from my experiment that you can see here. So it was just to show you that this one is, the rhythm is pretty regular, which is not the case here. So this will have definitely a value that is more close to 1 than 0. So for us, like to detect arrhythmia, it's really useful. Then the EFP. So it's the other thing you can measure. So here is the action potential. I described it before. So it's the action potential. You can't record the action potential on the machine. So what you can measure is the electrical field potential that is represented here. And also it might be easier if you follow here. So here's like the action potential with all the different phases and the correspondence of it with all like the implication of like the sodium and then the calcium and when it's happening and all of that. And this is an actual recording from our cells. So to show you that definitely we were able to see it. And if you remember like the EKG, as I was talking before, it definitely looks like we are doing an EKG on our cells. So that's kind of what you can do with the machine. So this is what I got, the results when I did controls versus 3 disease cell lines, 3 different mutation in calmodulin, like 2 different genes. You can see that first the beat rate is impacted, so the cells are beating like slower. But what is really, really cool is that you can see that there is a delay in the repolarization for all of them. And so that's what we were expecting. So that was really nice. So all the parameters you can have in case you want to know, like you want to use it later. You can also have the beat rate that was slower for all of them, the amplitude, upstroke velocity, the relaxation velocity, and then the pulse width, 50%, which reflects a longer, in our case, like repolarization, which is definitely what you can see for the 3 mutation compared to the control. And then here it's a screenshot. I thought it was really cool for you to see actually what you see on the machine and how consistent the signal is. So I just took like here, like 3 columns out of the 12. So except like 3 wells, you can see like, so sorry, the signal is like flipped, but you can see like this little, like, I don't know, bump that shows that there is a delay in repolarization. And you can see it on this cell line and also here. So it's, that's why you would observe. And so it's a like, you can record like for 48 hours or more, 24, as long as you want. And it's live, like you can see the recording. You don't have to wait the end of the experiment to see what's happening. It's like really live. So then for the electrical field potential, for the controls, so you can see, as I was saying, so kind of the QRS waves that you would see on the EKG. So this is the depolarization of the cell. And then we have the T wave, the repolarization. So for the control, it was around like 650 milliseconds. And so even like without zooming, we can see that it's longer, but it's easier. So it's the same scale. It's 100 milliseconds here. So this one was like switching to 800, and this patient was even like way worse, 1500, which is really extreme. But this is what we expect from the disease. Something I also said is that you can use optical and electrical pacing. So here's the electrical pacing that we are using. We've used 0.5 hertz. Usually you would do 1. It's just that the cells are like, the phenotype is so strong that if we try to pace at 1 hertz, the cells will not catch, even if we leave them like for 5 hours. We have tried, so we had to lower the frequency. And so just to show that even when you pace the cell, you can see exactly the same thing. The distance between here and the repolarization is way longer for the disease line. So if you pace or if you don't pace, you don't lose the phenotype. Then what is really interesting, and maybe will be more interesting for all of you, it's, I guess this machine was designed to use for drugs and to test drugs more. So this is a screenshot from like Nanion. You can see that they use the quinidine. It's sodium channel blocker, and you can see all separation like of all those little arrhythmia. So they would be, if you remember one of my first slide, that would be a DAD. So when like you're back to repolarization, and then you would see another contraction when it's not supposed to happen. Then for the EFP, they tried nifedipine. It's a calcium, the cardiac calcium channel blocker. And you can see there is a dose response. So the more you add by blocking the calcium, you will reduce the time between depolarization and repolarization, so contraction and relaxation of the cardiomyocytes. So then we were like, okay, let's do the same on our cells. So we used isoproterenol. So it's an agonist of the cardiac beta-1 receptors. So what you expect to see is the cells beating faster. So that's what we had. So black is baseline, no drugs. Red, 1 micromolar of isoproterenol. And so you can definitely see that the cells are answering and are beating faster. And since they're beating faster, the field potential durations of the time between depolarization and repolarization is also shorter, and that's what you would expect. Then I did the same on the disease line, the calmodulin line. So baseline, we had like 9 beats in 30 seconds. We usually record 30 seconds at a time. I added the isoproterenol. I got an answer. That was cool. Switched to 9 bits to 23 bits in 30 seconds. And then that's when I saw a difference, is that all the cells, because I had like 24 replicates, died after 20 minutes. So I got like no signal. And it was not the case for the control. So apparently the calmodulin line, they do not handle well the isoproterenol, which I forgot to say that isoproterenol is something that would mimic, like in a patient, when a patient is like biking or having an exercise, if you want to, I lost a word. If you want to do the same thing, like mimic the same thing on the cell, you would add isoproterenol. It's like a stress. It's like the cells biking or swimming if you want. Then I did another one, E4031, which is a class 3 antiarrhythmic drug. So this one is blocking the potassium channel. So if you remember, it's the repolarization of the action potential, so the N. So you would expect a problem in the repolarization, so longer time. Regarding the impedance, we were able, not for the control, but for the calmodulin, to see that it was like definitely having an impact on the repolarization at 0.01 micromolar. And for the EFP, so black is baseline, no drug. Blue was the addition of the drug. It's an actual screenshot for the machine. So the machine is like doing that for you. When we added 0.1 micromolar, we saw the prolongation of the repolarization. We switched from 300 to 700. And even if like the calmodulin line, like baseline, they are definitely already prolonged compared to the control, we still saw a prolongation. We switched to like 900 to 1500. So the same E4031, we were able to see what we were expecting from them, which is prolongation in the repolarization. So back to my project, I'm gonna give you, I've been able, so it's been like a month and a half, I guess. Yeah, the first time I've been able to do the first comparison between category 1 and category 5. So what I'm going to show you is preliminary results. So of course on the Flexcyte, and also calcium imaging, even if I didn't really describe the machine. Oh, that was supposed to be switched, sorry. So first the calcium transient that is represented here. So this is the average of, the average. So black is category 1, blue is category 5. And so there is like it tends to, the category 5 tend to have like a higher amplitude compared to category 1, but it's not significant so far. And when you look at the calcium transient duration, so the peak value, as I said, the upstroke velocity or downstroke velocity, we do not see. There is like a lot of variability. So just to give some details, in category 1, I've been able only to do like 4 cell line against 6 in category 5. And so category 1, I had like 1 biological replicates, let's say, per cell line, and for some category 2, only 2 biological replicates. And we want to do the 12 cell line, and for each cell line having 3 biological replicates. So there is more to be done. And then for the impedance, for the Flexcyte, so what I got, so the same, I do not have significant difference between the impedance, bit rate regularity, pulse width, upstroke velocity, and relaxation. And I mean, it makes the slide a little bit like crazy, but I just wanted to show you. So here are all the code for my for 6 controls, and here 6 patient. And it was just to show you the variability. So like this one is like the same patient is like 2 biological replicates, and so we have a pretty strong variability, and that's why so far we don't see anything. So definitely I have to do more replicates. So what's the next step for my project? So I've showed you for the Flexcyte impedance results, but I haven't analyzed the EFP part at the baseline. So that's what I'm doing right now. And then I did, so on the Flexcyte and on the calcium imaging system, I've used 5 different drugs. So isoproterenol, caffeine, E4031, flecainide, and verapamil. This is a calcium inhibitor. This is a sodium inhibitor. This one I've showed you, it's a potassium inhibitor. And those 2 are known to be like a stressed trigger. So I've done 5 different concentrations with this range. And so I will analyze that for all the cell line, category 1, category 5. So then I will also, the next system that is ready to be used is the synchro patch, the automatic patch clamp. So I will record the sodium, calcium, and the action potential of all those lines. And as I said, I will repeat all the experiment to have at least 3 biological replicates. So the conclusion of right now the presentation is that the recruitment is done, which is very cool. All the high throughput system are like up and running, and it can be used. The first result we have, like, it suggests a high calcium transient amplitude, but we definitely need more replicates. As I said, I will finish the analysis, and hopefully with the drug addition, we will see a difference between category 1 and category 5. I will proceed to the synchropatch experiment, and we are also planning to do RNA sequencing from category 1 and category 5 from the cardiomyocyte. So the big conclusion of the project is that this project has been designed to improve the prediction of the sudden cardiac risk in order to improve patient care management. And so, as I said, there is like 2 projects. The one on the left is the algorithm that will be used based on genomic data from the whole genome sequencing of all the patients that have been recruited. And then on my side, I was trying to do that. I'm doing that with an in vitro model. So what we hope is that both of them, they will predict, and they will be able to tell the patient, yeah, you're in high risk category, or no, you're not. And since it's going to be a little bit complicated, like long term, like in 5 or 10 years, it takes time to take blood, reprogram the cells. It's like from 3 to 6 months. So it's really long. But if we're able to predict the score based on genomic data, long term, the patient would have a genome sequencing, a whole genome sequencing, and the physician would be able to tell the patient, yes, you definitely need like a different treatment, or you need more, or you need an ICD, or you do not need. And so with this, we predict that we were able to accurately classify patients as low or high risk based on the RS score. So I would like to thank everyone that is working on this amazing project, and my lab, and mainly Dr. Burridge and everyone in my lab. And I'm happy to take any questions. And thank you for listening. Oh my God. No, it's good. Oh, that's good. Does anyone hear me? Sarah?
Can hear you. So if anybody has any questions, they can put it in the chat, or I don't know. Let's see. I can let you, I think everybody should be able to unmute themselves now. Maybe not. There we go.
Yeah, I had a question.
Okay, sure.
Yeah, so very interesting results. Thank you. I was a little bit confused about exactly what machines you're using and where they are. This is just like a very practical matter. So you showed a lot of cardiac action potentials, right? Recordings, yeah?
Yeah.
So what machine are you using to record those? Is this the synchropatch that you're using to record those calcium action potentials? Is that right?
So to measure the action potential, yes, it would be this machine, the synchropatch.
Okay, so the results you showed with all the different cardiac action potentials, that was using that synchropatch, right? And is that the synchropatch that is currently located in the pharmacology department?
Yeah, so the synchropatch is in Dr. George lab. This one is in our lab, and this one is in our lab, but it's available for the core. And yes, so what I showed was the calcium transient was from this, and the electrical field potential and the impedance, it was from the Flexcyte that is available in the core.
So the synchropatch is in pharmacology. Where physically is the core then, where the calcium imaging apparatus is?
So you mean this one isn't available in the core, it's only the Flexcyte. And so it's in the pharmacology department on the 8th floor.
Okay, so physically speaking, all these instruments are situated in the pharmacology department?
Yes.
Okay, and the synchropatch, because I know there's a synchropatch that is that Carlos uses
Yes, that's this
And
one.
in fact, I've done some experiments with that, but I just wondered if this was another one that you're using or whether it was the same one. Okay, so there's just one of them around and it does these recordings. Okay, all right, so that explains it. Thank you very much. Thank you.
Anyone else have any questions? If not, Mallory, that was really great. Thank you very much. You did a great job promoting the core for me. And so I guess we can call that a seminar.
Okay.
And everybody have a great day.
You too. Thank you.
Thank you. Bye.
Bye.
Bye-bye.